all the best for the coming examination. Don't be in tension, but you will be in tension. Please hydrate yourself with water. Drink plenty of water. And let whatever will happen. Now, meninges of brain and spinal cord. Now, this is the skull cut. It is like this. The total, you will be seeing, viewing. This is very important. Now, this is the base of the skull with the bones of the cranial cavity, and this is the lesser wing of sphenoid, anterior sphenoid, greater wing of sphenoid, Sellae tarsica, clevius, foramen magnum. As you have not read the osteology of the cranial bones, so when you have the classes for osteology, you will be knowing more. Next. Now you see, this is again the piece, the major bone. This is sphenoid, this temporal bone, parietal bone, occipital bone. Now the frontal bone and ethmoid bone. These compose the total skull. And next. Now, brain and spinal cord by Dura Mater, Arachnoid matter and Pia Mater. Now, subdural space filled with capillary fluid, subarachnoid space filled with CSF, subarachnoid space enlarged to form cisterns. Dura Mater is called Meninges. Arachnoid and Pia Mater together is called Meninges. Now, these are the terms which you will encounter in study of the brain and the spinal cord. Brain and spinal cord covered by Dura Mater, Arachnoid matter and Pia Mater. Now, subdural space is filled with capillary fluid. Subarachnoid space is filled with CSF. Subarachnoid space is enlarged to form cisterns. Dura Mater is called Meninges. Arachnoid matter, Pia Mater together is called Meninges. Now, Dura Mater, non-elastic fibrous membrane. Now, cranial dura has endosteal and meningeal layers, and spinal dura mater has meningeal layer. Now, meningeal layer of cranial dura mater has inward processes. Dural venous sinuses are present only in cranial dura mater. Epidural space is not present in cranial cavity. This epidural space is not present in the cavity, cranial cavity. Non-elastic cranial dura mater, outer endosteal layer attached to margins of the foramen magnum and continues with periosteal lining of the orbital cavity. Inner meningeal layer forms processes which is continuous with spinal dura mater at the foramen magnum. At Sellae tarsica, all three meningeal layers are blend intimately with fibrous capsule of the pituitary. Now, processes of the cranial dura mater. Now, Falx cerebri, a sickle-shaped, this is the Falx cerebri, a sickle-shaped fold roof of the skull to the medial longitudinal fissure. This is the sickle-shaped cell, the medial longitudinal fissure. Anterior end is fixed to the crista galli and posterior end blends with the Tentorium cerebelli. This is the Tentorium cerebelli, and the convex margin to the lips of the sagittal sinus. The convex margin in the sagittal sinus, when you open the skull and you view, you will be seeing the impressions of these. Now, the convex margin to lips of sagittal sulcus, concave margin is free and closer to corpus callosum at posterior part. Now, straight sinuses is lodged between the line of fusion of Falx cerebelli and Tentorium cerebelli. Terminates in the left transverse sinus. This is the left transverse sinus. Superior sagittal sinus in superior sagittal sulcus terminating in the right transverse sinus. inferior sagittal sinus along inferior free margin. Yeah. Now tentorium cerebelli projects in transverse fissure, presents an attached margin at the periphery and free margin at the forepart of the median plane. Posteriorly, tentorium is attached along margins of the transverse sulci. Now, transverse sinus laterally attached to the upper border of the petrous part, superior petrosal sinus. These are the sinus, venous sinuses. Next. The anterior end of attached margin is fixed to the posterior clinoid process and crossing of attached and free margin laterally. Inferior layer of tentorium forms cavum trigeminally. Free margin presents U-shaped tentorial notch. This is a U-shaped tentorial notch. Anterior end of notch is attached to the posterior anterior clinoid process. An oculometer trigone. Next, diaphragm sella. This is the diaphragm sella. Horizontally oriented circular fold forms roof of the sella tarsica, front to tuberculum sella and behind to dorsum sella. Upper layer is continuous bilateral with the roof of the cavernous sinus. Falx cerebelli, sickle-shaped process extending from internal occipital crest to the posterior cerebral notch. Process has occipital sinus. Now, when you know the cranial bones, when you are studying the osteology of the cranium, then it will be more clear. But now you can see this is the Falx cerebelli, dural sinuses and dural folds. These are the and inferior sagittal sinus, tentorium cerebelli, superior sagittal sinus, and Falx cerebelli. Now, spinal dura mater, only meningeal layer, cranially the margin of the foramen magnum and blends with the posterior surface of the C2, cervical 2 and cervical 3 vertebra caudally through phylum terminally till posterior surface of first coccygeal vertebra. Okay, provides tubular sheath along spinal roots. Ligamentum denticulum attached to the inner aspect of the dura mater. Now, this is the dura mater, this is the subdural space, and these are the denticulate ligaments, arachnoid mater, this is the arachnoid mater, subarachnoid space, Pia Mater, epineurum of spinal nerve. Now, dorsal root ganglion, and this is the spinal nerve, ventral root, this is the ventral root. When you dissect, you will be seeing the total image of this picture. Next. Now, epidural space. Epidural space between spinal dura mater and periosteum of the vertebral canal extends from foramen magnum to the hiatus sacralis, contains fat, loose areolar tissue and internal venous plexus. Now, over here the attachment of the dura in the foramen magnum of the skull, and this is the posterior aspect of the sacrum, and over here at the hiatus it is attached, the phylum terminally. Now, extends foramen magnum to hiatus sacralis. Now, contains fat, loose areolar tissue and internal venous plexus. Internal venous plexus communicates with the tributaries of the caval and azygos vein. Metastasis from carcinoma prostate affects vertebral bodies. segmental and regional anesthesia by introducing anesthetic fluid in epidural space. Now, I previously showed you when I spoke on vertebra, and now arachnoid matter closely applied to dura mater separated by subdural space. Subarachnoid space is narrow over the cerebral gyri. This space is wider in some parts of the brain and caudal to some. This space is wider in some parts of the brain. Caudal to termination of spinal cord forms cisterns. Next. Now you see the cranial arachnoid, subarachnoid cisterns filled with CSF and traversed by several blood vessels. Now, this is the cistern, and this is the medulla oblongata, this is cerebellum, this is part of the corpus callosum, this is cerebrum, peduncle is here, optic chiasma, and pons, foot ventricle is here, and cisterns are lined by Pia Mater and Arachnoid matter, skips from promontory to promontory. Now, cranial arachnoid, subarachnoid cisterns filled with CSF and traversed by cerebral blood vessels. Cisterns are lined by Pia Mater and arachnoid, skips from promontory to promontory. Now, the sacral promontory, it goes from the cranial. Next, now the cisterns, 3 cisterns ventral to the brain and hypothalamus, pontine cistern, interpeduncular cistern, chiasmatic cistern, 2 cisterns dorsal to the brain stem, cerebellomedullary and superior cisterns, cisterns of lateral fossa, cistern of lamina terminalis, supracallosal cistern. These words are very new to you, and when we start the classes or lectures and demonstration of the cranial bones and the skull, it will become more clear. Now, this is just see that what is contents, what are dura mater, what is Pia Mater, what is subdural space. Now, because of the other day I told you when I told you spoke on the content or windows to the nervous system. That's just a picture of what you ought to study in brain and spinal cord. Now this you just see the vascularity of the brain. Now at this subdural, if there is a trauma in the skull or anything, and the subdural spaces, their vessels are ruptured, injured, and the consequences is that subdural hemorrhage. Now, next, pontine cistern contains basilar artery above with interpeduncular cistern, below with spinal arachnoid space. Now, this is below with the spinal arachnoid. So, if there is an injury in this level, then it's an MRI or your MRI or CT brain, especially MRI, then you will be seeing the hemorrhage. Now, will it be conservative or according to the lesion and the trauma, the severity of the trauma, you will be finding the content, the blood clot or some hemorrhages is there. So, accordingly, the neurosurgeon will plan and the surgery to be performed. Pontine cistern contains basilar artery, above with interpeduncular cistern, below with the spinal subarachnoid space, behind with cerebellomedullary cistern. These are the cisterns. This is the chiasmatic cistern, interpeduncular cistern, pontine cistern, superior cistern, and the cerebellomedullary cistern. Now, if there is a skull, there is an injury there, then in the subarachnoid space there will be hemorrhage. Accordingly, how much damage to the brain is there. If it is continuously like you get a trauma and there will begin a hemorrhage, but it will be the severity of the injury, the quantity of the blood that is collected in the subdural space. You have to do MRI, and then accordingly the surgery will be performed. Now, now, interpedunculaar cistern located in front of the interpedunculaar fossa, okay, interpedunculaar fossa, and in front of the chiasmatic cistern, okay. In front with the chiasmatic cistern contains circle of Willis. Now, the circle of Willis, the blood supply, the circle of Willis comes as a short question. Describe the circle of Willis and next. Now, chiasmatic cistern related to optic disc, pre and post chiasmatic cistern contains anterior cerebral artery. So, if there is an injury, it will be reflected. Cistern magna under surface of the cerebellum and lower part of the medulla contains this is the chiasmatic cistern, interpedunculaar cistern, pontine cistern, and superior cistern and intermedullary cistern. Now, you just describe, the question can be a short question of 5 marks, that name the different systems of the brain. The cisterna magna, under surface of the cerebellum and lower part of the medulla. This is the medulla lower part, this is the part. Now, continuous with the subarachnoid space and pontine cistern. Receives CSF and from ventricular system. Cistern ambience between splenium and cerebellum, greater cerebral butt, and cistern of lateral fossa across lateral sulcus contains middle cerebral artery. Next. Now, this is the arachnoid granulation, fleshy macroscopic elevation. These are the fleshy, this is the arachnoid granulations. See. And the arachnoid matter, arachnoid projects into the venous sinuses. These projections, so if there is any injury of the brain, then there is hemorrhage in the cisterns, and you can see the granulation, arachnoid granulation. This is the arachnoid villi and subdural space. This is subdural space, and this is the arachnoid matter, subarachnoid space. So you can see this is vascularity. If there is a trauma, there is injury, then subdural space, there will be collection of the hemorrhagic fluid. And if the hemorrhage continues and there is a collection, that will be manifested in the system, nervous system. Now you can see the spinal arachnoid. Now, the spinal arachnoid extends up to lower border of the second vertebra, second sacral vertebra. This. And spinal nerves receive investment from the arachnoid. Here, corpus medullaris, chorda equina, this is the chorda equina, hilum terminal. This is a dissected specimen, the picture of a dissected specimen of the spinal cord. And the spinal cistern lies distal to the caudal end of spinal cord, intervenes between L1 and S2. L1 and S2. Cistern contains CSF, rootlets of chorda equina, hilum terminal. What is the content? Describe the spinal cistern and what are the contents of the spinal cistern, and CSF aspiration between L3 and L4 spine. Now, when I told you regarding the vertebral column, you have to give a spinal tap in meningitis in the ward. So, this is the level to collect CSF. If the patient is having meningitis or your encephalitis and any hemorrhage, then you do a spinal tap, get the CSF, send it for biochemical and related examination, because very important. You can, in the emergency, when you get a traumatic patient with head injury, then you do a spinal tap, you will know if it is hemorrhagic and what. By the time you resuscitate the patient, and then you do an MRI. But it will be depending on the condition. So, clinically you diagnose how much you can, because immediately the surgery cannot be performed. You have to get all things in the file of different investigation and different biochemical and this type of examination. So, CSF you have to take out. It's not like you get a spinal needle. Nowadays, there are very fine, and the patient won't go into shock or something like that. You have to just in lateral position, you cannot make him sit or this thing, and you put it in lateral position, and you see the CSF aspiration between L3 and L4 spines. Now, clinically, a patient is admitted with hypyrexia and also symptoms of meningitis, signs of meningitis. So, clinically you diagnose, you take a spinal tap. Not every pyrexia or every fever you will be collecting CSF. You have to clinically diagnose that if it's meningitis or your encephalitis, then you have to take the CSF fluid and send it for biochemistry and other related examination of the spinal fluid. And the level where you will put the spinal needle and tap, do the spinal tap, then it is in the level of L3 and L4. Pia Mater and CSF, Arachnoid Pia, now Pia Mater and CSF. Next. Now, thin vascular membrane. Now, this is called thin vascular membrane. Now, outer vascular is highly vascular. Outer epipia form the arachnoid mesothelium. Outer epi and pia form arachnoid mesothelium. Inner pia intima formed by the fusion of plial mesothelium, basement membrane and astrocytes. Cerebral Pia Mater, telecordia and choroid plexus, bilaminar pile fold along roof of third ventricle and roof of the fourth ventricle. Telecordia provides choroid plexus. Now, telecordia of the third ventricle. Now, triangular pile folds, corpus callosum and fornix above, thalamus and third ventricle below, the apex toward the IV foramen of Monroe, the base between the splenium and tectum. It contains CSF, choroid plexus, pair of internal cerebral veins and commencement of the great cerebral vein. Now, if there is a head injury and if the hemorrhage is in the imaging this how much damage it is, damage done. Now, thalamus nuclei is there. So, if slowly in these regions, you cannot directly go and operate immediately. So, it will be depending how much the trauma is, and the manifestation will be accordingly in the clinically. Now, contains CSF, choroid plexus, pair of internal cerebral vein, commencement of greater cerebral vein. Now, this is the sagittal section of the third ventricle, and this is the cerebellum, this is the corpus callosum, this is the cerebellum, this is the pons, this is the medulla, and you can see the infundibulum, linea terminalis of the corpus callosum, and this is the thalamus here. From when you read the brain, the thalamus, it on many connections there, which is controlling many activities of the brain. So, a short note can be on thalamus also. And next, now two sides of the triangular fold projects into lateral ventricle as choroid plexus. Choroid plexus, this is the lateral ventricles. And round thalamus to each other, choroid plexus winds round the thalamus to reach inferior horn of lateral ventricle. Now, upper limb of the choroid fissure between fornix and thalamus, lower limb between the stria terminalis and fimbria, choroid plexus of lateral ventricles extend as plexus of the third ventricles, telacordia of the fourth ventricle, bilaminar pile fold between inferior vermis and fourth ventricle. This is the inferior vermis. Now extend to the nodule of the cerebellum and continues with the cisterna magna, ventral lamina of fold interrupted by foramina of Meninges and foramina of Lasca. These foramina, Meninges and foramina of Lasca can come as a MCQ or a short note. Choroid plexus of the fourth ventricle, two vascular fringes of Pia Mater in the form of inverted T and projects into the ependymal roof of the fourth ventricle, and vertical limb forms pair of longitudinal fringes. Horizontal limb extends along the lateral recess of the fourth ventricle. See, this is the cerebellum, this is the pons and the anterior medullary, and this is the posterior medullary valve, and choroid plexus. This is the choroid plexus, and this is central canal. This is central canal. This is the medulla. This is the pons. Next. Now, blood-CSF barrier. This can be a short note, and when you even the placental barrier, placental barrier, CSF, blood-CSF barrier. This can come as a short note. Placenta, I'm told when you are doing embryology, you are taught placenta. Naturally, I'm telling you these are the components where the question can come. The blood-CSF barrier, and I'm saying in embryology, you will be coming with the term with placental barrier. You write a short note and what is its function and how it works. Now, see, this is the CSF and this is the blood. Now, this is the choroid plexus and blood CSF barrier. This is a very good picture, and you can draw a picture like this, illustrate, and then write the note. Now, fenestrated epithelium of choroidal capillary. This is fenestrated epithelium. Incomplete sheets of pile stromal cells and ependymal cells resting on basement membrane. Weaker thin blood-brain barrier. Weaker thin blood-brain barrier. Now, blood-brain barrier. Excuse me. Now, blood-brain barrier is another component. So, CSF barrier, blood-brain barrier, placental barrier. Now, no fenestrated endothelium of the capillaries, non-fenestrated endothelium of the capillaries, there is no fenestration, and the vascular basement membrane for vascular endothelium, perivascular feet and cell bodies of the astrocytes. Now, this is the astrocytes. These are the astrocytes, and bodies of the astrocytes, cell bodies and processes of neurons. See, blood, lymphocytes, macrocytes, neutrophils. So, blood-brain barrier is in cells. The tight junction, there is very closely, the tight junction is there, and the basement membrane. And you see the astrocytes, microglial, brain. This is the brain. This is the brain. This is the next blood-brain barrier. Now, spinal Pia Mater. Now, see spinal Pia Mater. Hilum terminal, non-nervous filamentous. Non-nervous filamentous. There is no neurons or this thing. Above the conus medullaris, opposite L1. This you have to know hilum terminally. Even when you are doing gross anatomy, and if you are asked to hold the spinal cord, then the examiner will definitely question you on spinal terminally. And short note on spinal terminally. Now, caudally pierces dura and arachnoid opposites S2 and blends with the periosteum of the first coccygeal vertebra. here. Now, proximal 15 centimeters within the dural sheath and rests outside. Upper 5 or 6 centimeters has central canal of spinal cord, the terminal ventricle. Next. Now you see the linea splendens, median glistening line of Pia Mater along anterior median fissure. This is spinal cord, anterior median fissure, you will see the linea splendens. Now Pia Mater, these are the denticulate ligaments. Arachnoid mater, this is the arachnoid mater, and dura reflected. This is taken out, dissected and opened up. And you are seeing that the anterior mater, arachnoid mater and dura mater reflected, and this is the Pia Mater. Now Pia, dura, arachnoid. Now dorsal root of cervical nerve C6, ventral root of cervical nerve C6. This is the dorsal root and this is the ventral root. Spinal blood vessels. This is the blood vessel. See, beautiful, dissected. This spinal. Now, the ligamentum denticulum, this could be a short note. Pile sheet between ventral and dorsal roots. 21 triangular teeth-like processes. First tooth is the foramen magnum. Last tooth is T12 and above L1. This is the ligamentum denticulum and the description. Subarachnoid septum, mid-sagittal sheath from arachnoid along posterior median sulcus. Next. Cerebrospinal fluid. Now, clear, colorless, odorless, fills ventricular system and subarachnoid space. CSF possesses higher sodium chloride and magnesium ions and then plasma. Now, when you do a spinal tap, then you please go give an order that test for sodium, biochemistry, chloride and magnesium ions, then plasma. CSF is formed from choroid plexus, ventricle, diffusion from brain and pile vessels. Now, how the CSF is formed from the choroid plexus of ventricles and diffusion from the brain and pile vessels. Now, circulation of CSF. Now, see the choroid plexus of lateral ventricle to foramen Monro. These are the two ventricles are connected with foramen Monro. So, it moves up through the adequate aqueduct of Sylvus, fourth ventricle, foramen of Lasca and Magendie and cerebellomedullary system. This can be a short question. So, you have to give what is the CSF flow. Now, you can see the different levels where it is here, choroid plexus of lateral ventricle, foramen of Monro, third ventricle, aqueduct of Sylvius, fourth ventricle, and foramen of Lasca and Magendie and cerebellomedullary system. Next. Now, CSF circulates into two directions, caudally along spinal subarachnoid space, caudally along subarachnoid space, dorsally through the tentorial notch, along inferior and superolateral surface of the cerebellum, and reaches the arachnoid villi for absorption. Higher pressure capillaries to lowest pressure of venous sinuses. This is unique to the circulation of the CSF, that higher pressure capillaries to lowest pressure venous sinuses. Quicken stent test. Now, lumbar puncture between L3 and L4 spine at 1 drop per second. In normal condition, compression of intervertebral, in between the intervertebral discs, the lumbar puncture increases CSF pressure. Herniation of medulla and cerebellar tonsils through foramen of magnum may result in cardiorespiratory compromise. So, if you can see if there is any injury to the brain, then these are the manifestations. So, if a patient with trauma comes with the respiratory and higher your CSF pressure, then the intense headache after lumbar puncture CSF for diagnosis of various diseases like tubercular meninges that I told you. Now, intense headache after lumbar puncture. Actually, what happens when you do a lumbar puncture, then few patients, they complain of severe headache. You post lumbar, this thing, your spinal anesthesia. Like on the day one, the operation was done, the lumbar puncture was done, naturally for spinal anesthesia, then the headache manifestation occurs within 16 hours or 24 hours. Severe headache. Then you have to manage with paracetamol, and even you give a black coffee drink, 3 cups, and plenty of oral fluids, IV fluids, and that reduces the, I'm saying any patient with the lumbar puncture for spinal anesthesia and also lumbar puncture for your any infective disorders like tuberculosis or encephalitis and anesthesia. Now, hydrocephalus. External hydrocephalus, excess fluid in subarachnoid space, excess senile atrophy of the brain. Internal hydrocephalus, usually congenital, dilatation of ventricles due to obstruction, communicating hydrocephalus, flow of CSF obstructed in the interval between tentorial notch and midbrain, pneumoencephalography, ventriculography and myelography. These are the mode of radiological investigation in hydrocephalus. See, this is the ventricles, no hydrocephalus and hydrocephalus. See, this is the normal ventricle. Now you see the swollen, enlarged. Okay, and this is the hydrocephalus. A baby with baby is born, you see some big head. Then you think, you think that it is a hydrocephalus. But with modern USG investigation in the antenatal period, so 18 to 20 weeks, you have your anomaly scan. Then if it is detected that it is hydrocephalic, then you counsel the mother and parents that this baby will have a big head. And there are no such centers, but that baby will be handicapped. And there are some operations that from the ventricles in the chamber of the tube is put in, so the excessive CSF fluid goes into the circulation. Now, thank you.